Between 2011 and 2015, the number of children presenting to the ED for behavioral health concerns at Rady Children's Hospital in San Diego increased by 500%. To decrease the need for emergency behavioral health care services and to improve the early identification and treatment of symptoms, the Rady team developed their Transforming Mental Health initiative, which integrates behavioral health services into the pediatric primary care setting. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly with AHA Communications. In this Members in Action podcast, Rebecca Chickey, AHA's Senior Director of Behavioral Health, is joined by Domonique Hensler, Senior Director of Care Redesign Planning and Mental Health Integration, and Dr. Benjamin Maxwell, Interim Division Director of Child and Adolescent Psychiatry, to discuss this care model's positive outcomes for patients, families, and providers.
Thank you, Tom, and welcome to Ben and Domonique. First of all, I want to thank you for your willingness to not only go on the journey that you're doing to improve access to care for children and adolescents in need of mental health and substance use disorder services, but even more so, your willingness to share this journey, lessons learned, and the inspiration to others of how they can improve access to behavioral health services for the pediatric population. And I also want to call out the fact that from the materials that you've shared with me before, you have gone on this not just in one journey to integrate physical and behavioral health better, but to build on that through community partnerships, looking at the opportunities that are out there, whether it's through pediatric offices and other channels where our children, our adolescents are seeking care and may have a behavioral health need that can be addressed right then and there. So I just so much appreciate this. And my first question to you is, why? Why did you start on this journey to integrate physical and behavioral health and also to go outside the four walls of the hospital? Because that's not always easy. So would love to know what the inspiration was.
What a wonderful question, Rebecca, and thanks for having us. Ultimately, we think health is the integration of psychological and physical wellness. So integrating these things in our clinical programs just kind of made natural sense to us. Here at Rady Children's Hospital, we started on that journey probably, and you can really trace that back to 2012 when the inpatient psychiatric hospital was moved on to our main campus, really in an attempt to bring us closer to the other subspecialists that are here on the main campus. And there's more integration and collaboration between psychiatrists and behavioral health providers and some of the medical subspecialties we have here. Around that same time, we also opened the medical behavioral unit. So looking at the medical comorbidities related to eating disorders and treating those in the same clinical program with behavioral health expertise through family-based treatment, and also adolescent medicine, looking at some of the things that come from negative consequences from eating disorders from the medical perspective. It kind of morphed further in 2015 when, as an organization, we set out to really be innovators in whole child care, what we call whole child care, looking at how do we, independent of the door that a patient or family walks in, we are considering their psychological well-being in concert with their physical health. So, for us, it was really this natural step to then start thinking about, well, how do we integrate behavioral health expertise in the primary care setting? How do we really try to identify behavioral health needs as early as possible, and in an environment where kids and families feel comfortable, they have trusting relationships with their pediatrician, and really ultimately just wanting to create a system of care that makes sense for kids and families. And that's why we've started working with some of the entities out in the community, because that's where that care is provided.
Right. And it was an interesting moment when Ben spoke about 2015. Between 2011 and 2015, the number of children presenting to our emergency department in crisis in that time period increased, in mental health crisis, increased by 500%. And we were alarmed. We were seeing the trends increasing in self-harm among 10 to 14-year-old girls with social media available 24/7 on the smartphone. It had tripled the levels of self-harm nationally. The amount of high school students that were feeling sad or hopeless increased 40% between 2009 and 2019. This is all pre-pandemic. And so it was really important to us with our covenant to the community and as a safety net provider to take a step back and think about, we've got this wonderful continuum of care of services we've been able to put in place for children in crisis, whether it's our emergency department. We also have a behavioral health urgent care in pediatrics as well, crisis stabilization, and so on. But how can we prevent? How can we identify early and intervene? And Ben, you may want to talk about the depression screening we started rolling out system-wide in 2016.
Right. I mean, I think it's a good point that you bring up, Domonique. I mean, again, it goes back to the idea that no matter where you enter into our system, we want to start identifying kids as early as possible and then be able to intervene as early as possible. Our thought on that is it makes it easier to treat. It takes less resources to treat if we're intervening early. There's good evidence for that in psychosis. There's something called duration of untreated psychosis being linked to worsened outcomes for people with those issues. But the same is true with anxiety or depression. You know, ultimately, we see a lot of kids on our inpatient unit that are 15, 16 years old, struggling with depression, social media difficulties, a lot of times suicidality. And when we talk with their parents, a lot of times they say, well, you know, this really all started when they were 5 or when they were 6 and they were anxious. And then, you know, then they were 10 and they didn't have any friends. And then they were 12 and started feeling sad and had more social anxiety. And these things build and build and build on each other. And a lot of these kids and families are just not getting the support they need. So it really drove us to say, how do we, with limited resources, figure out the most high impact program to change the trajectory and move the needle on this a little bit? And we're really proud of what we're doing with mental health integration and happy to share more with the audience here.
So with the word integration is huge. Where do you start? Where did you start? Was leadership on board? And for those wondering, how are you doing this financially? I'm going to ask that question and weave it into that because I think how the hospital leadership is involved, you know, also means how you were seeking to make sure that this is a financially stable, sustainable program. So where did you start? How is leadership engaged and how are you keeping this going? And congratulations, you started in 2011. Wow.
Yeah, excellent question. You know, I think I broadly covered what we were doing throughout our entire organization, but we specifically started very informally with the idea of mental health integration in primary care clinics. So that was an informal group of people throughout the community, academics from universities in the area that had an interest in the topic, pediatricians that were kind of doing it on their own, heads or leaders of community mental health programs that were interested in expanding to some of the programs they had, psychologists, social workers, psychiatrists. There was about a group of 20 of us that in 2017 started meeting informally. We all talked through, hey, what would it look like if we had a mental health integration project that really tried to get all the pediatric clinics in our area, this sort of service, embedded behavioral health expertise in primary care. And there were a lot of different opinions. There were different opinions on how to do it, why to do it, what the best approach was going to be, how are we going to fund it. And we met for about 2 years. And we at that point really felt like we had an idea of how we could, as a community, come together and really create a program that could work. But then to the second part of your question, there wasn't a clear way to fund it. And so we had an opportunity that Domonique will touch more on, but we had an opportunity that kind of fell from the sky of a philanthropic opportunity that could support something like this. And because we had that community organization and community engagement on an idea, when that philanthropic opportunity fell from the sky, we were ready to pitch an idea that could work and be implemented pretty quickly and immediately. Now, how do we do that ongoing without philanthropy support? I think that's something we're working through, and Domonique's going to be the one that figures it out, I think.
Yes, no pressure. But there's no more noble cause. I've been in hospital administration almost 30 years now, and I'm really excited because it's bringing together our business acumen with our medical acumen and mental health to really look at whole person care. The reimbursement streams are bifurcated, as we know. There's parity issues in mental health that have not been addressed. The legislation that was passed in 2008 is disparately and inconsistently implemented in states throughout the country. So there's a lot of education and policy and payer advocacy work we need to do to ensure that mental health treatment and related services are on par with what an insurer can provide under medical services. And we also need to look at network adequacy and utilization review, make sure it's, equitable. So these are other areas that we are looking into as part of an initiative we're calling Transforming Mental Health at Rady Children's. So again, focused on that whole child, and we're piloting this primary care mental health integration program that we were just so fortunate to have a donor in 2019 say, this sounds exciting and it's what we should be doing because we don't want to see as many children in crisis. It breaks our heart when 6-year-olds are coming to our ED suicidal. Like, we're seeing young children. This is a problem. And it was well before the pandemic. And so the pandemic has only shown a light and exacerbated it. But to date, with our primary care mental health integration program beginning in summer of 2019, we have now implemented 8 primary care offices where we have embedded what we call integrated health therapists, IHTs. So they are literally part of the practice team working side by side with the primary care provider. And we think the combination now of doing this together is really reaching the definition of PCMH, the primary care medical home. They're working together, and we're doing comprehensive longitudinal care plans. The pediatrician or primary care provider, the MP or PA, is the quarterback of this child's care. Our therapist is also part of our multidisciplinary integration team that includes psychiatry, care coordination, and clinical supervisors. We all meet weekly in the PCP office going over the registry and a population health-based approach to identify proactively all patients that could potentially benefit from this. We're also calling it intentionally integrated health therapy because it can also help with the value proposition of how do you manage populations of chronic medical conditions or other barriers to adherence to a treatment plan, for instance, diabetes or asthma. There could be psychosocial impediments there that could affect a patient, whether it's a child or adult, adhering to the plan, and it can improve your capitation utilization management performance as well. But what's so beautiful about it, and Ben can speak more to this, is whether we proactively identify through a panel of patients that we're reviewing, or the PCP identifies during an annual well child visit, either through depression screening or patient history, a need, or the patient can, bring it up, or the caregiver, mom, dad, auntie, grandma brings it up, they can immediately ping the therapist located less than 30 feet from the exam room and do a warm introduction.
Yeah.
And that has been really impactful in these models that we learned from, mostly in the adult health space, to vouch for mental health, to normalize mental health and destigmatize it. And it's almost like got a therapeutic effect that we hear you, we're here to help you, I vouch for this person, give it a try. And it's conveniently all located where you're familiar, because you know me too. I've been, treating your child, or I've been treating you since you were a peanut, and I'm here to help you. And then that introduction, if it happens that same day as the visit, our therapists sometimes can immediately be available to meet with them and start the intake process. And then our model in the PCP practice is goals focused and solutions focused. No more than 4 to 6 visits. It's very measurement based. And then we've also stood up 3 regional support hubs for mental and behavioral health services for more long-term traditional work if children are scored or screened or assessed at a higher risk or need more care than our problems-focused short-term modular work could do in the PCMH setting. So it's really exciting and encouraging that we've been able to be in the fortunate position to set up this network of care devoted to this in the last 2 years.
So I have a couple of statistics for those who may be cautious or skeptical about whether or not a child and adolescent can really be mentally ill. I do think our society has now moved from when I first got into this field in the 80s to a whole different perspective. But just to level set the importance of this, according to NAMI, 50% of lifetime mental illness can be identified by age 14. You talked about the need to be proactive, the need to have early intervention. And one of my actually personal friends and colleagues is Dr. Stefan Heckers, who has done a lot of work on first psychosis, the first break. So if 50% can be identified by age 14, NAMI also says 75% of lifetime illnesses can be identified by the time an individual is 24. So if we can, just like an individual with diabetes, with high blood pressure, with, congestive heart failure, whatever it is, if we can identify these illnesses early on, after all, the brain is actually part of the body. I'm glad we're finally figuring that out, right? This work, particularly in early intervention and prevention, is so incredibly important. So that was my, for all listening, that was my soapbox. This is why it is so important. If we can treat this early and often, as often as it's needed, then we will be ahead of the game, and the quality of life and the productivity of the individual can be elevated in a way that in many cases we have a missed opportunity right now.
Well, and Rebecca, you hit the nail on the head. And here's the other thing, along with those powerful statistics, when I, shifted gears to be able to lean in on this incredible opportunity to really, work on the missing puzzle piece of whole person health and wellness, I said to Ben, help me understand, though, our volume is out of control. So it's more than just what we've seen in the normal course of some mental health conditions developing. And I think that there's been some environmental factors that have increased the amount of children at risk. And so what this model does is while they're still in the mild to moderate, while we can catch them when it's typically undiagnosed, like anxiety in the younger ages, that can then progress to a harder to treat depression when they're a teenager, then we may be able to change the trajectory of health for these children, and it'll have a huge impact on healthcare spend and utilization. Our mental health integration work right now amongst our 8 locations and then our 3 hubs is showing a 2/3 reduction in depression. Imagine what kind of cost reduction that could be if more programs like this were widely spread. But Ben, keep me honest, is that right that, given your expertise and experience, that we have, a tidal wave now of more children experiencing mental health concerns than ever before.
Oh, I mean, without a doubt. And I think that's why I think it was the Children's Hospital in Denver that announced a state of emergency because the number of mental health crises arriving in their general emergency department. It's why we've seen the massive increase in our general emergency department. We see it all over the media, this crisis that's coming for parents, for kids growing up in today's environment. It's harder and harder for kids. And after the past 2 years of the pandemic, more and more kids are struggling. Rebecca, I loved your point of we all have a brain. And there's not one of us that's going to go through life that isn't going to need coping skills, strategies to deal with anxiety or depression. We all have this need. And so why not think through ways to start when kids are very young and make sure we're building the best brains we possibly can with a healthcare system that makes sense for those kids and their families. So I think now is sort of this golden opportunity that we've all sort of started to realize that we have underfunded, underinvested in this area, and it's time for change, and it's going to impact our society on many, many levels if we can do this successfully and band together as a healthcare system in our country to really do things different and transform mental health.
So just a couple of thoughts, and I'm thinking about those listening right now. I want to let people know when they're thinking about what can I do that's actionable, both in their own organization, but also at a national level. AHA is part of an initiative called Sounding the Alarm for Kids. And that is, I encourage people to Google it, to get involved. We're just one of several partners that's raising this awareness. And I also think the current administration, as well as previous administrations, is acknowledging this. And, the current environment, I am old enough to have grown up without Twitter. And so, but the social media, while it has such positive power in terms of positive outcomes, it's also something that, like most things, there's two sides to the same coin. And I think it has created some challenges to our current youth. So as we begin to wind up this podcast, you just mentioned, so Ben, I'm going to ping on you. What do you think are some of the key success factors that have really allowed you to get to this point? In all transparency, I'm hearing passion from the two of you. I'm hearing collaboration, both inside your organization as you moved the inpatient unit into your children's hospital, as you began the integration. I'm also hearing a commitment to whole person health. And I just want to take this moment and say that's bi-directional, right? That's not just addressing the mental health needs of a child and then finding out if they have physical health issues. I assume that you're also coming at it from the other direction. What do you think are the success factors, and what do you want people to remember? Like an action step they can take or something to do after they listen to this podcast?
I think one of the key success factors that we've just been fortunate to have is hospital leadership and community leaders that have been into this. They think this is the right thing to do. And that was said by previous hospital leadership, current hospital leadership, leadership of major group pediatric practices, that they all have been sort of the champions of this in their careers even before this idea came together. So we had, I think, probably the perfect combination of people that were willing to do this, even though there isn't a clear financial argument to do this. And I think the leaders that were involved just said, we are the only pediatric hospital healthcare system in San Diego County. We're going to do this because it's the right thing, and we'll figure out how to make it make sense at some point. And so we were fortunate to have that. And because of that good fortune, one of our goals really is to come up with the recipe or the way forward for other organizations so they don't necessarily have to take that leap of faith. So that's one of the things, one of our goals is to figure out, hey, what's the right recipe? What's the way to make this viable? What are the funding opportunities? What are the ways that you prove value? What are the ways we advocate and change the system so that this could be a regular part of care? The second part of your question of what is there to remember, or what would I hope people remember about what we're doing? I think it's the idea that everybody has, that there is no health without mental health, and pediatricians are aware of the idea that a lot of their kids are struggling from a psychological perspective. They don't feel they have the time, they feel they have the training, and they don't have any sort of referral network to make a difference. And so a lot of times there's reluctance to dive into those conversations. One of the things we've seen is, as we train people, as we create a system of care that can absorb kids that are struggling in real time, those pediatricians never want to go back to the way it was before. They are more and more advocates of the mental health of the kids that they're seeing, and they're not avoiding it anymore. And so, although culture change is hard, both for the pediatricians and, quite frankly, for behavioral health providers that practice in this environment, which is new for a lot of us, it's hard to make those changes. But once we've made those changes, none of us want to go back, because it makes us feel so much more impactful in our daily lives and in the work that we're doing. So that's, I think, the thing I'd encourage folks to see is, yes, this is hard work. There's not a clear path forward in the current environment. But once we go down this path, most of us don't want to go back.
If I could add a couple of other success factors, Rebecca.
Absolutely.
Great. It's important to have the governance and the leadership, and part of that flows through is champions. So we have clinical champions ranging from primary care office site champions to others throughout the broader team that make a difference on this. The other piece that is needed is, once you have those champions that can convince others, like it was literally Dr. Ben Maxwell here and our specialists that convinced many of the providers throughout our entire clinical integrated delivery system that we're going to start screening for depression at every visit starting in 2016. It took those brave soldiers, if you will, to be able to put it out there and say, this is the right thing to do, and we're going to do it. Well, with integration work, you also then need to bring along your providers so that they can then be trained on what I call mental health 101, signs and symptoms, how to recognize, how to start a basic treatment plan, and just entry-level psychopharmacology that we then, with our psychiatrist stakeholders, help to consult on cases. So over 170 of our providers in our network have been through a training through the REACH Institute that has done a really great 2.5-day fellowship with 6-month of case-based follow-up. But you have to give them that training. But we also have to retrain the mental health workforce that is used to what I call the Bob Newhart model of, I'm going to book you for 6 months of visits. I haven't even come up with a full care plan, and I'm assuming you need just ongoing time on the couch. No, we are reaching outcomes by using this goals-focused model. So we're also looking at how do we retrain the workforce. And then again, it comes down to partnerships, a lot of communication, having the shared EMR platform and all of those related things work as well, along with through our capitated books of business, we share risk on a variety of products. And so it's not to say that we're going to just depend upon this very generous gift we were given to pilot mental health integration in pediatrics. We are looking at Medi-Cal fee-for-service codes that can be used. There are Medicaid and Medicare collaborative care codes that exist, big C, little o, big C, and big M. But they are more for a very adult Medicare population.
Yes.
So we're looking at what do we need to do for pediatrics, because there's a lot of family work involved, a lot of parent work as well. So we have to look at it differently.
Wow. I wish we could keep this going for another at least 30 minutes, but we might start losing listeners. So I am going to say, Domonique, thank you so much. Dr. Ben Maxwell, thank you so much for the work that you're doing and the willing to share that experience with others. And through this, inspire others to go on this journey. I will say this, I don't have any hard statistics, but the reality that I can name now at least half a dozen to maybe a dozen children's hospitals who are doing something similar, not the same, but something similar. And I would put them in they're identifying the mental health of the children and adolescents in their care as a top priority. That to me gives me hope, so much hope. So thank you so much for your time today to record this podcast. Very much appreciated.
Thank you for having us on, Rebecca.
Thank you so much.